Hello everyone. Today we discuss sleep disorders in children. So we have this international classification of these sleep disorders. So international classification of sleep disorders. So first type is insomnias. Second one is sleep related breathing disorders. Third one is central disorders of hypersomnolence. Fourth type is circadian rhythm sleep wave disorders. Fifth type is parasomnias. Sixth one is sleep related movement disorders. Seventh type is other sleep disorders. So these are the types of sleep disorders. Next we'll go into their evaluation and diagnosis. Okay. So we'll see the evaluation and diagnosis of these sleep disorders. So first method is by asking question, that is sleep questionnaire. Okay, this pediatric sleep questionnaire was prepared by Sherwin. So this pediatric sleep questionnaire, it was prepared by Sherwin et al. It has a sensitivity of around 0.85 and specificity of around 0.87. This sensitivity and specificity is mainly based on a questioning in well children from age group of 2 to 18 years. Okay. So this is the first useful screening tool in the primary care. So this is a useful screening tool in primary care. Third, it is not a good screening tool for children with complex disorders. So it is not a good screening tool in children with complex disorders. So complex disorders that includes example neuromuscular disorders, craniofacial anomalies, and Down syndrome. Okay, this is about the sleep questionnaire. Next is actigraphy. So second evaluation you do is actigraphy. So what is this actigraphy? This is a device that is worn on the wrist like a watch. Okay, this device is worn on the wrist and it records the movements. So this it records the movements. These movements, that recorded movements, are used to estimate the sleep parameters. So these that are used to estimate the sleep parameters. The sleep parameters includes sleep onset, sleep duration, and wake time. Okay. So it is a well validated tool for estimation of nighttime sleep parameters. But to this to be used as a validated tool, there should be at least 2 weeks of recording. 2 weeks of recording is must. And this can be objectively document the sleep patterns. So they can objectively document the sleep pattern and evaluate the treatment outcomes. These are useful in evaluating hypersomnias, insomnias, and circadian rhythm disorders. Okay. Next is sleep studies. Third evaluation is sleep study. So this test that records the physiological parameters while the child is sleeping. So this is a test that records physiological parameters while child is asleep. Okay, so a good sleep study should have a total sleep time of at least 6 hours. So there should be a total sleep time of at least 6 hours. So the diagnostic sleep studies include, what are its components? So this diagnostic sleep study includes, first is overnight oximetry, second oxycapnography, third cardiorespiratory polygraphy, fourth is complete polysomnography. Okay, first we'll go into a oximetry. So this is done by using a timed pulse oximeter. Okay, so this is done by using timed pulse oximeter. So average time is a crucial setting in this evaluation in diagnostic efficiency of this oximeter. So average time. This average time is crucial is a crucial setting in the diagnostic efficiency of the oximeter. So when this average time is longer, for example, if it is 8 to 16 seconds, if it is long as 8 to 16 seconds, its advantages, it will reduce, there will be reduced signal artifact. So there will be a reduced signal artifact, but they have a reduced ability to detect the rapid change in saturation. So but they have reduced ability to detect the rapid change in the saturation. So therefore the average time of 2 to 3 seconds is being used. So this can maximize the diagnostic efficiency. So this can maximize the diagnosis efficiency. Okay, this is about the oximetry. So in oximetry, if the saturation, that is SpO2, drops below 90% in the nocturnal oximetry test, this is an indicative of moderate to severe this obstructive sleep apnea hypopnea syndrome. So this will be a indicative of moderate to severe obstructive sleep apnea hypopnea syndrome. Okay. Next we'll go into this cardiorespiratory polygraphy. Second one is cardiorespiratory polygraphy. This study includes 3 channels. One is respiratory channel, second is cardiac channel, third is body position channel. So what are these channels? We'll see it in detail. Okay. Channels. So first you have nasal cannula, second is thoracic and abdominal belts, thoracic and abdominal belt, third one is body position sensor, fourth is microphone, fifth one is video recording, sixth is ECG, seventh is this oximeter, that is pulse oximeter, eighth one is for measuring this carbon dioxide, is transcutaneous or end-tidal capnography, ninth you have EEG, EOG, 10th is leg EMG. Okay, so how are these being used and what are its function? First, nasal cannula. This can detect apnea and hypopnea. Second, thoracic and abdominal belts can detect the respiratory effort. Body position sensor, for this body position, whether the child is in supine, prone or in a lateral position. Microphone, whether the child is snoring or not. Video recording for the body movements. ECG for the cardiac rhythm. Oximeter to detect the saturation. Carbon dioxide to detect the hypoventilation. It is capnography. EEG and EOG to detect whether there is a presence and the presence of the sleep and the stage of the sleep, and then to detect the presence and the stage of sleep. Leg EMG to know the periodic limb movement. Okay, so if in a cardiorespiratory polygraphy, you will be having this nasal cannula, thoracic abdominal belts, body position sensor, microphone, video recording, ECG, oximeter. This will be an optional one, and this both will not be present. Okay, this is in cardiorespiratory polygraphy. In polysomnography, that is complete polysomnography, you will be having all the things here, including EEG, EOG and leg EMG will be present, that which is absent in this cardiorespiratory sleep study. This is the difference between cardiorespiratory polygraphy and complete polysomnography. Okay, next, most important parameter defining this sleep disordered breathing in sleep study is apnea hypopnea index. Apnea and hypopnea index. So this is the most important parameter that is defining the sleep disordered breathing in sleep study. Okay, so what is this apnea hypopnea index? So definition of this apnea hypopnea index is number of apneas and hypopneas per hour of the total sleep time. So that is number of apnea and hypopnea per hour of total sleep time. Okay, in obstructive apnea hypopnea index less than 1 is considered as normal. That is apnea hypopnea index less than 1 is considered as normal. 1 to 5 is classified as mild obstructive apnea hypopnea index. 5 to 10 is moderate. More than 10 is severe. Okay, so this is about the sleep study that is involving cardiorespiratory polygraphy and polysomnography. Next we have multiple sleep latency test. Multiple sleep latency test. Okay, to evaluate the children with excessive daytime sleepiness and are diagnostic for this narcolepsy. So this is used to detect the children with or evaluate the children with excessive daytime sleepiness. And are diagnostic for narcolepsy. Okay, this is the multiple sleep latency test. Next we'll look into the indications of this diagnostic sleep study. So what are the indications of this diagnostic sleep study? First is the respiratory indications. So children with a day-to-day problems or day-to-day activity which is getting disturbed due to adenotonsillar hypertrophy, second, when the genetic syndromes involving craniofacial syndromes or genetic syndromes involving craniofacial anomalies. So these can include Apert syndrome, second Crouzon syndrome. Okay, so Apert syndrome and Crouzon syndrome. Next, other genetic syndromes such as achondroplasia, Down syndrome, syndromes that is related to obesity, such as example Prader-Willi. Next is mucopolysaccharidosis. Okay, so these are the indications. Secondly, neuromuscular disorders with suspected nocturnal hypoventilation. So children with neuromuscular disorders with suspected nocturnal hypoventilation. These are children with SMA, that is spinal muscular atrophy, Duchenne muscular dystrophy, third congenital muscular dystrophy, fourth children with congenital myopathies, fifth children with congenital myasthenic syndrome. Okay, next non-respiratory indications. Third, we have the subtitle as non-respiratory indications. So this non-respiratory indications, these include children with hypersomnolence. Second, restless leg syndrome. Third, insomnias. Okay, so these are the indication of this diagnostic sleep study. Thank you. I hope this is a short topic on the sleep disorders in childhood. Thank you. Next topic will be approach to IEM. Okay, sorry, I have not completed my approach to IEM in detail. So next we'll look